Well, let's focus a little bit on some clinical cases, and I hope to be provocative enough to you. So, according to, this is the old picture from the treatment of acute respiratory distress syndrome, and as you can see here, ECMO was on the top. But what I'm going to propose you is to include a new protocol, which includes core combined with inhaled nitric oxide and prompt positioning in case that our patients are very hypoxemic. So maybe the role of ECMO is over. Now, let me present you my first case. This is a 64-year-old man. He's a post-surgical patient, duodenal pancreatectomy. And on day 4 after surgery, he presents a severe respiratory failure that requires intubation. He's on SpO2 below 80% despite an breathing oxygen fraction of 100%. The cause was a suture failure, and he was operated the next day. So let me present you this data from the patient. This is before the orotracheal intubation. The patient was on non-invasive ventilation. You can see here that the patient is doing quite well in terms of ventilation, although he's very distressed, he's very tachypneic, a lot of work of breathing, but he's very hypoxemic. So we decided to intubate the patient. After intubation, you can see here that there is a terrible drop in pH, a dramatic drop in pH, and increase in PCO2. This is quite often seen if you are dealing with these severe patients. You see that very often, that when you intubate the patients, they lose their spontaneous breathing. Actually, they lose a lot of ventilation, and sometimes you can expect this dramatic acidosis. The PO2 did not improve either, so we just waited a little bit more to see what happened. After 3 hours, the patient was still very hypercapnic. Oxygenation had improved a little bit because of we had prone the patient, started our nitric oxide, as is usually in my unit, but he was not ventilated either. He was not improving the ventilation. 22 hours later, we had to take the patient to the operating room. So finally, after 22 hours, the patient, after the surgery, he was still very hypercapnic and acidotic. So we decided to, our patient was on SOFA 9 with a RESP score. If you're not familiar to this score, it has been validated by the ELSO and estimates the probability of survival on ECMO of these patients. So this patient on ECMO, actually in this moment, he had a probability of survival of only 33%. And actually he filled some ECMO criteria according to the EOLIA trial, which I think they are very, very well, they're very correct. Actually, he filled 2 of these criteria in terms of oxygenation and also ventilation. So we decided to start a core, as you might imagine. So we are a little bit crazy, and instead we are an ECMO center. Okay, we were an ECMO center at the time, but we have been familiar to the core for some months, and we tried to give the patient an opportunity. He was just operated. We didn't got to go into the ECMO of this anticoagulation, of this mess. So we decided to start our core. And actually, after 3 hours, this is the small membrane, the CO35. We are talking about the old Prismalan that used the neonatal ECMO membrane. And you can see that after 3 hours, he starts to improve both pH and PCO2. And after 9 hours, it's completely normal, our patient. So he was weaned finally from a core after 5 days, 5.5 days. And on day 2 after echo removal, the patient was doing very well. He was actually on pressure support ventilation. And we were just weaning the patient. He still was hypoxemic, but he was doing quite well. Unfortunately, he had a massive hemoperitoneum and shock, and we could do nothing for him, and he died. He had an artery in the abdomen that literally exploded, and we could not do anything for the patient. So this is my first case. Actually, it was disgrace. But actually, the core in a very, very complicated patient actually served to overcome this respiratory failure. And this patient is included in this series of cases that we published in 2020. This is the first 10 cases with ECMO criteria that actually were treated with a core in my unit. These patients, 10 of them, all of them, of course, they filled the criteria for a core in terms of for ECMO in terms of ventilation, but also 5 of them had hypoxemia that could be leading also to an ECMO. But you can see here on the slide that after 3 hours of treatment, only 2 of these patients actually remained on the PF ratio that was recommending to start an ECMO. And after 24 hours, only one. You can see that patients also, 4 of these 10 patients actually, although they had ECMO criteria, it was contraindicated due to coagulation problems or the age. All these patients had a RESP score of 33% estimated survival, so they were really very severe. The PCO2, when we started, was 81 mean, and it decreased after 3 hours to 60, and after 24 hours, it was almost normal. And you can see that we were using the small membrane. And the pH also, we started at 715, so we were really very, very restrictive to start our record, but actually after 24 hours, the pH was completely normal. It was published in European Journal of Anesthesiology. The time of a core was 91 hours, the mean. We could wean 9 of the 10 patients from a core. 1 of them died during the core treatment, but it was a malignant arrhythmia. It was a cardiac surgery patient, nothing to do with respiratory failure. Actually, we extubated 5 of the patients, but we had a very high mortality. We could send to the ward 4 of these patients. 2 of them died in the ward for different causes that we don't have time to discuss now. So these were extremely severe patients that could overcome this respiratory failure thanks to the core. Now, this is my second clinical case. This is a 44-year-old man. He's also post-surgical. It's a lung resection that after admission to the ICU has a rapid onset respiratory failure that required intubation. He had an atelectasis, he had an air leak after the surgery, and also a pneumonia due to Staphylococcus epidermidis. Fine. So on day 1, he was very hypercapnic and increasing driving pressures. So this is blood gases before the core. He had a pH of 724, PCO2 of 80, and we had driving pressure of 15. I remind you that he was having some air leaks, and a tidal volume which was already very small. And the patient was doing worse. So we decided to start our core. He had a SOFA score of 8, and in this case, the RESP score, our estimated survival was 57% on ECMO. And this was also a patient with ECMO criteria if we consider only pH and PCO2. Well, after 9 hours, after 3 hours, actually the pH improved to 731, the PCO2 decreased to 63, and you can see that also after 24 hours, it was normocapnic. This patient could be weaned from a core after also 5 days. He was extubated on day 3. After the core removal, he was discharged from the ICU and from the hospital. So let me stop now our experience, because I started talking about these ECMO candidates, but we don't really need to be a candidate for ECMO. Although, as I told you before in my first presentation, we required a PCO2 of 60 and a pH below 725 to start a core. So in some centers, that could be considered as an ECMO indication. So this has been recently published this year in Respiratory Medicine. This is 79 treatments in 73 patients with a mean SOFA score of 12. So we are dealing with really very, very severe patients, a very high expected mortality. Our criteria for a core are those that I presented you in my first presentation. Actually, we allow plateau pressure up to 25 and a respiratory rate to 30 with a driving pressure of 15. So it's more or less the same as we published in our consensus paper on 2020, although driving pressure we allow up to 15 instead of 14, but it's almost the same. Half of them, a third of them had severe ARDS as defined by the PF ratio below 100, and 40% of the patients were COVID-19. We use prone positioning, nitric oxide, and steroids as usually in our unit in most of them. Well, this is the gasometric data. So PF ratio improved significantly, although clinically probably irrelevant. But of course, we observed a decrease in the PCO2, an increase in the pH, decrease in the plateau pressure, driving pressure, and respiratory rate. So all this is supposed to be very good for our patients. But I want to stress on this was not unexpected. Of course, we are dealing with a machine that removes CO2. But I want to stress on these items, these ideas. We defined early start of therapy within 6 hours after presenting a core criteria. And we did that in almost 50% of our patients. So we were very early in half of our patients. The median duration of therapy was 96 hours, which is around 4 days. Just compare that with the ECMO treatment. I think there is no comparison at all. If you were starting an ECMO, even a Windows ECMO, at least be 1, 2, 3 weeks. It was combined with renal replacement therapy in most of the cases. There are very severe cases. And the median fluid balance, I want to insist also on this part, was minus 185. So we could do an equilibrate balance in our first 24 hours. ECMO is very preload dependent, and this is, I would say, impossible. At least in our experience, it's very difficult to get this neutral balance in the first 24 hours. Usually you have to overload your patients, which goes directly to the lung if it's inflamed. Adverse events. In this, we agree with the study that has been previously presented by Professor Kong. We didn't have really any adverse events. We defined adverse events, severe thrombopenia. We found that in 4 cases, which I suppose we skipped some of them because we are talking about SOFA score of 12. So probably we are missing some of the cases with severe thrombopenia. This is expected in these severe patients. We had only 1 case of aggravated hypoxemia, but it was resolved just increasing the FiO2. We had oozing, but no severe hemorrhage at all. So we coincide with Professor Kong that there were not severe hemorrhage in any case. Overall mortality was very high. We're talking about very, very severe patients. So it was around 70%. But it's important that's why in my first presentation, I insisted on early treatment with a core. Also, Professor Samir has also talked about the early use of a core. You can see here that when we analyze our patients, according to the starting moment for a core, when we started early, the survival was significantly higher than in those patients that we started a core late. So it was a survival of 56% versus 78%, mortality, 22%. So I think it's very important to do an early treatment with a core if your patient fills the criteria. The hypothesis is that you are just blunting an inflammatory response, which is very fast to be developed. And we saw that in the COVID pandemic, when your patient was very hypercapnic for, let's say, 1-2 days, it was sometimes very difficult to come back to a normal situation. It's like the lung, once it's inflamed, it goes very fast. And it's difficult to recover. This is a hypothesis, of course, but I think early a core should be instituted. And another important finding was that the size of the membrane is very important. You can see here we have used 3 sizes of membranes during our history. You can see here that there was no difference in the mean duration when you're using the small membrane as compared to the intermediate membrane. It's almost 80 hours. But when you use the large one, the 1.8 square meters, which is almost an ECMO membrane, with these low blood flows, it lasts half of the time because it clots very easily. Now, let's go to my third clinical case. This is a 60-year-old woman, a small woman. I insist on this. This is 155 meters, 52 kilos. Yeah, she had a clinical history of lymphoma. She required radiotherapy. And as a result, she had some mediastinal fibrosis and ventilatory restriction. She was operated of a mitral valve replacement and a tricuspid ring. She had all kinds of complications. She was in cardiogenic shock because of right ventricular ischemia and required a stent on the right coronary artery. She also had an intra-aortic balloon and vasoactive agents. She had a postoperative pneumonia, bilateral pleural effusion, so it was a complete disaster. She was on sustained respiratory failure, and so she required tracheostomy on day 12. The compliance started to be around 20 in the first days, finally reached 10 after these 2-3 weeks. And she was on sustained tachypnea. She had a bacteremia, renal failure. So on day 30, she was not doing well. She was going worse. And so we decided to prone the patient, start nitric oxide and a core. This is our blood gas. She had a pH of 715, PCO2 of 74. And you see that after 10 hours of core, we could improve it. It was more on the alkalotic side of the 743 of pH and PCO2 of 34. Day 3, well, she's not that good, but she's still doing well with the core. But the system clots. It was around 6 a.m. in the morning. In my unit, it's the nephrology nurses that have to take care of these machines. So our nurses called them, and they took about 1 hour and a half to come to change the line. So in this 1 hour and a half, you can see this dramatic drop in the pH and increase in PCO2. Actually, the patient insisted that she was small because the ECCO was doing practically most of the function of the lungs. So once she could not tolerate just 1 hour and a half without it, despite having a driving pressure of 15. So she had a cardiac arrest, initial successful resuscitation, but we could not save her. She was in shock, and she finally died. Now, this is not a poll. So just, I want you to think, what would be your answer to these questions I'm making you? So do you think that the nephrology nurse was responsible for the bad outcome? She took a long time to come? Or a course should have been started earlier? Or maybe it's not a core. We should have started an ECMO. Or finally, the patient should not have been treated with any extracorporeal device. It was useless to do that. I think the answer, there is no correct answer probably, but I think D is the right one. I think this is a case that we were so confident in a core that after 30 days of mechanical ventilation in a restricted patient that had all kinds of complications and was doing even worse, probably we should have had to stop the treatment. It was useless. And now my last case, this is a clinical case 4. This is a 67-year-old male with severe COVID. Well, he was an ECMO survivor. He had severe COVID in the past, and he came last year to our hospital with a progressive pulmonary fibrosis. And he was being evaluated for pulmonary transplant. He had a respiratory failure, and he was admitted to respiratory intermediate care unit because in this moment he had an intercurrent process. This is the CT scan. Let me show you if I can. No, wait. I will, here it says, let me show you the CT scan. You can see here that actually he has no lungs. It's a terrible situation for the patient. So the miracle is that he was still living. He had dyspnea, cough, pollen secretions, and fever. A respiratory rate of 40 with a very intense work of breathing. Well, he had an intercurrent infection. So it was, we could save this, we could pass this infection in a few days. Probably he could recover, and then he might be a candidate for lung transplant, but not in this moment, of course. And actually, the medical ICU rejected this patient to be admitted because they would not intubate him. They say, well, if he does not survive without intubation, we can do nothing for him. And if he's intubated, he will never be a candidate for transplant. So our colleagues, well, they tried this is pneumologists that were taking care of this patient, high flow nasal cannula, non-invasive ventilation with high pressures. So they could improve the pH, but still the patient was very, very tachypneic and a high work of breathing. So they just called us and say, can you try your machine with us, please? So we started an echo therapy. It was for 6 days at 300 minutes per minute. And the patient finally was discharged home with a nasal cannula, and he was a candidate for pulmonary transplant. And this is my last slide, so thank you very much for your attention.